Hi guys, so for my opioid project, I wanted to look at the effects on early physical therapy for low back pain and stepping away from opioids. So we all know that opioids are known for having a significant decrease in pain. However, we've also learned and seen the side effects of opioids. And some of the research that I found was that there's actually no functional improvement after opioid use, and there's only in specific patients there is improved quality of life and function, but we do know that with opioid use there is a higher risk and higher harm rates with the management of subacute and chronic low back pain. And the majority of the harms are typically seen in the GI system and the nervous system, both of which side effects that often are associated with opioids, such as dizziness, nausea, vomiting, and constipation. We can also see withdrawal symptoms, and a lot of times the patients aren't often educated that this is a syndrome that can happen from that. In one of the articles that I found actually brought the question up with why they wanted to know the reason behind why we're prescribing opioids for treatment of subacute and chronic low back pain when non-opioid options such as NSAIDs are available, and they obviously show significant fewer harms and side effects. Along with that, there's non-pharmacological methods to treat low back pain and have been recommended in literature that suggests that PT is a positive alternative. So then there are benefits to early PT, but timing of the PT referral and treatment appears to be a big determining factor when we're looking at the outcomes of patients with low back pain. Studies also show that patients that saw PT first had significantly lower opioid prescription rates, advanced imaging, and emergency room visits. Along with this, there was patients that had early physical therapy for their low back pain ended up experiencing less surgery, injections, and need for specialists, which ended up reducing the overall cost and significantly lowered their out-of-pocket expenses, pharmacy expenses, and outpatient costs. But I do think that noting that they're less likely to be prescribed opioids is notable given the increasing awareness on the overprescription of opioids and the high risk of substance abuse, and the importance of the role of the provider. So then that leads me into some interventions that I found that we would be able to use for some of our low back pain patients. And the first one that I saw was maintenance of trunk stability. And so what that consists of is like a pelvic tilt or abdominal hollowing. I wanted to note that these are typically only used in the initial phase because there's not enough evidence or research to prove the long-term outcomes of strengthening from these exercises, but there is research and evidence that proves that they are good for the initial phase to work on dynamic stabilization. And this is because maintenance of the trunk stability relies on synchronous muscle activity, and inappropriate contraction of even one muscle could result in a force sufficient enough to disrupt the stability. So it's really important for our low back patients to teach them and practice with them, working on all of their muscles working as a team, because even just with one muscle not working right, it could lead them into some instability. Then I had some low stress aerobic activity, and I wanted to note that these don't always work for every single patient, but research does show that general conditioning exercises such as bicycling, walking, and swimming are usually indicated for low back pain patients. And early on in the course of chronic low back pain, low stress aerobic activity, especially walking, has been shown to be superior to bed rest or inactivity or that sedentary lifestyle, and we all know that. And the current evidence seems to show that active rehab is the best way to, and the best approach to manage back pain. And so I think that just kind of re-emphasizes everything that we've been taught so far about sedentary lifestyle is not great for our body. Even if our patients are feeling pain, they're going to want to sit down and rest, and that's okay to a certain extent, but really getting our patients up and moving to prevent that low back pain into a chronic low back pain. So then I had some adjunctive therapies, and that includes spinal manipulation. For this one, there was a lot of research that said that it reduced pain, but there wasn't enough evidence for long-term outcomes. So then there was biofeedback, and it's not directly affecting the pain, but it does help allow the patient to use it as like a cue for the muscles to relax at night, which ends up reducing pain at night. And then lastly, for the adjunctive therapies was massage. And so essentially that just relaxes the muscles, which decreases pain, increases range of motion, and it also included that it improves the overall mood of the patient by decreasing depression and anxiety. And lastly, there is the McKenzie method, which is an active therapy that involves repeated movements and sustained positions, and has an educational component with the purpose of minimizing pain and disability and improving spinal mobility. And so this method involves assessment of the symptomatic and mechanical responses to repeated movements and sustained positions. And so the study actually showed that disability measures showed that the McKenzie method was better than the manual therapy method at improving long-term patient functionality. So just for some final notes for you guys, the goal of this is not to completely eradicate opioid use, but rather to provide comprehensive management of pharmacological and non-pharmacological options. And so the physical therapist would have to be a part of the interdisciplinary team, with their role primarily being giving or delivering non-pharmacological pain management options, like some interventions that I just previously talked about: strong stability, low stress aerobic activity, adjunctive therapy, McKenzie method. Those are just a few that I found. I'm sure that there's many others. And so this is because we are the musculoskeletal experts. And the physical therapist on the team must be aligned with the overall team goals, given the complexity of the decreasing or stopping opioid usage, especially for patients that may be presenting with signs that are consistent with opioid use disorder. And then here are my references. Thank you all for listening.